All right, welcome to Duke Spine Institute. Dr. Duke Majan here with my team. Our patient has traveled from Brazil. He's here because he has a thoracic disc herniation at T8-9 that is causing back pain and narrowing of his spinal canal. He has additional herniations lower and I think one above, but his pain he pointed to was right here. And we just marked out where is T8-9 on the x-ray, and you see the line right here, Henry? This line right there?
Yes, we do.
It lines up pretty much perfectly with T8-9, which the report says is where his herniation is as well. His pain is more on the left side. So today, we're going to be treating a T8-9 herniated disc, partially calcified. It's basically not calcified. It's actually got some bone spurs, but no, it's not calcified. So it's really a soft herniation, T8-9 from a left approach. Let's bring the fluoro in. So welcome to our live stream. Feel free to ask some questions. I'll do my best to answer them for you. We're only fixing one disc. It'll be from the left side. All right, let's start with showing the video on how does a herniated disc cause back pain. Where's my marker? No, the metal marker. Always.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.dukespine.com.
No? Let's try it. All right. Okay, welcome back. You've seen now how a disc problem can cause pain. Look at this x-ray. This is an AP front back. The arrow's pointing at the rib. Look at the rib of T12. Now look below it. There's no rib, right? There's a transverse process. That's got to be L1. So the last rib is T12. That means the pedicle there is T12, and then we count the pedicles up. T11, 10, 9, 8, which means my marker is right at the T8-9 disc, exactly where we want to be from the left approach. So we're perfectly where I want to be. All right, next step is going to be, let's lay still. That's me right there. All right, so I'm going to put some num-num, some numbing medicine. For those of you who don't know what num-num is, this is a concoction of lidocaine and marcaine. Don't move.
Keep your head still.
You're not going to like what happens if you do. You're going to end up not having anesthesia for the rest of the case. Then it's going to suck bad. So lay still. So I've given him some numbing medicine. We'll give it a chance to work. Lateral. 12, 11, 10, 9, 8. We may have to reposition based on where we are on the lateral, but we'll look. Most of the surgery is done with a lateral view. Again, we're fixing a thoracic herniated disc. All right, very good. So I need to see a little better north. You got to move north. You probably have to wag north, my side north, because your pedicles are offset. Shot. All right. That looks pretty good. You're doing great. Lay still, okay? Shot. Now I gotta make my way down to the T8-9 disc. Shot. Don't move.
Don't move. Keep your head still. Head still. Head still.
He's not going to make it easy, is he?
We can go deeper, but then I can't. We can.
Just put him deeper. I don't care if he does the discogram or not.
Okay.
We need to get this done. And I can't do it with him moving around. Just put a little pressure. Is this num-num?
That's not enough. Yes, sir.
Lay still.
Try to keep your head still. We're going to give you some more medicine here. Get you comfortable. We're not using any narcotics. So not narcotic therapy.
Uh-huh. That's fine. That's where we are. All right, so he's moved a little bit on orbit. I think you're gonna have to bring my side up. There you go, try that. Try more. Maybe we're too far. Don't move. No, I don't think we're too far. Keep going. That's, that looks pretty good to me. Shot. Shot. All right. Any way you can get that lined up better? I think we're off on WAG. Somehow he's moved a lot. That's I think that's better, right, Luis? Shot. Shot. Okay, give me an AP. We're going to check our levels again on AP. You can't really tell where you are on lateral. You gotta, in terms of what level you're at, 8-9, 9-8, 7-8, 9-10. I believe we're at 8-9 based on our original localization. Yeah, we're at 8-9, but let's go down and verify that. So we're gonna count ribs up, one down. Come on, take a picture. All right, so a little bit higher, go north by 1/2 inch. Shot. So there's, let's count. Pedicle of 12, 12, 11, 10, 9, 8. We're between 8 and 9. That's the 8-9 disc. I agree. Now let's go up to the cervical spine. Maybe a little less penetration. You're a little bit overexposed. Let's count down from the first rib if we can to verify from top to bottom, bottom to top. It's always good in the thoracic to verify top to bottom, bottom to top. All right, so there's the first cervical rib. Let's count. Well, yeah, so that looks like 1, 2, 3, 4, 5, 6, 7, and we kind of lose it. Let's come down just a little bit, and again, shot. All right, 1, 2, 3, 4, 5, 6, 7, 8, 9. So counting top down and bottom up, we get the same place. We're at 8, 9, so we're perfect. We're exactly where we want to be. And now I'm going to enter the disc using lateral fluoro to guide me. I want to get in about maybe halfway into the disc, 1/3 to 1/2. And then we're going to bring the guide wire. We'll do our discogram, guide wire, and then the endoscope. Shot. We're inside the disc. We successfully got in. Our patient is asleep because he doesn't tolerate being awake very well. Discogram. Disco. Shot. All right, shot. One more time. Very good. So this is inside the T8-T9 disc. And now we're going to move on to the laser part of the surgery. Go ahead. Where's the skin knife? Thank you. So at this point, we're going to put our guide wire down. We're going to make an incision, and then we're going to take the needle out, leave the guide wire. Shot? Perfect. Any questions?
Yes, we have a comment and 2 questions.
Let's take those, and then we will afterwards we'll show the video on how the Duke laser disc repair works. That's a 4 millimeter incision I just made. Shot. Now I've got to take this needle out but leave the guide wire. Shot. Okay, good. You guys see that? The guide wire is staying. The guide wire's purpose is to guide me. I'm going to guide this dilator in so we can do the surgery. But we'll take the question.
The first one comes
Shot?
from Trisha, and it's a comment. And
Yes.
it's from YouTube. Trisha said,
Hi, Trish.
I'm coming down the end of the month from Pennsylvania for 3-level thoracic, DLDR, and I cannot wait. So tired of sitting in a recliner in pain. So thankful I found you.
Oh, thank you so much, Trisha. We're so excited to get you feeling better. This is what you're going to have done. This patient's from Brazil, so he came a little further, and he said that in Brazil, there's nobody that can do the surgery. He's very thankful he found us. He said there's one doctor who does thoracic disc surgery, but he said there's a 35% chance you're going to be paralyzed from the surgery. That's what he tells everybody. And there's a 98% chance the surgery won't work. So talk about, preparing people for the worst. This surgeon in Brazil tells patients 98% chance the surgery I do won't work. There's a 2% chance it's going to work, and there's a 1/3 chance you'll be paralyzed when I'm done. I mean, wow. So I understand he doesn't want to do it. And then, of course, he said, the patient told me he charges a lot more money than we do. I was thinking maybe I need to move to Brazil. I'm just kidding. Brazil is a wonderful country. Don't get me wrong. But I'm very happy in Florida. Besides, I don't think my team would follow me all the way to Brazil. Okay, so the whole surgery, folks, is going to be done through this little tube. That's it. And by the way, this is outpatient. This patient's going to go home in 30 minutes after the surgery's over. Oh, what do you know? I made the incision too big. I made 1 millimeter too big. So I made a 5 millimeter incision instead of a 4 millimeter. Of course, I'm joking with you. 1 extra millimeter, not a big deal, right? But the point is, this is a very tiny incision. So, and everything's going well. I'm now feeling the back of the disc, or close to it. That's probably the facet. I have to get past it. I feel the herniation. We're inside. We got to go a little further in. All right, we are now into the annular tear, right where the herniation is starting. We're done with placement. So we're good. Take one more picture. There it is. So you can see the tube. We're going to do the whole surgery through that little tube. Any questions?
Yes, these next 2 come from JMC on YouTube.
By the way, we've lost 1 drop of blood. Here it is. Kind of splurted it around, but essentially 1 drop of blood. So this is bloodless surgery. There's no removing lamina or foraminotomy. There's no moving the heart over, taking ribs out, doing a costotransversectomy or a transpedicular approach. It's very safe. transforaminal thoracic. We've done now 20 patients at Duke Spine in the last 3 years with 99% on average elimination of pain, 99%. That's the average for the first 16 patients we did. And that's 1 year follow-up. So we had our first 16 patients. We looked at, well, how did they do 1 year after surgery? And they had 99% pain elimination that they had before surgery in their thoracic. So that's better than any other treatment in the world. And that's long-term, 1 year after surgery. 0 complications. All right, what's the question?
These next two come from JMC on YouTube. And first question asks, how come is it for lumbar screws to break after fusion?
So great question. How common is it for lumbar screws to break after a fusion? Great question. So let's talk about that. It's not common at all. Lumbar screws should not break after surgery. If the lumbar screws broke, there's a couple of reasons why they break. Some of the reasons are because of the patient. Some of the reasons are because of the surgeon. So what are the reasons screws would break? Number one, the surgeon used too skinny of a screw. So what diameter were your screws? Typically, I use 7.5 millimeter diameter lumbar screws, or sometimes I can't fit a 7.5 millimeter, so I use a 6.5. Rarely do I use a 5.5. But I will tell you this, a lot of surgeons that don't do very good surgery, they'll use a 4.5 millimeter diameter screw, and those break easily. So did the surgeon put too skinny of a screw? That's number one. Number two, did the surgeon put enough points of fixation? What does that mean? Well, if you have 6 pedicles in the surgery field, did the surgeon put 6 screws? You should put 6 screws because each screw is what's called load sharing, meaning that they take some of the weight of your body. So the fewer the screws the surgeon put, the more weight per screw, which means the higher the chance of fracture of the screw, which is what happened to you or somebody you know. Oh, herniation, you guys see it? Blue, beautiful. Oh, poor man is having so much pain. This is gonna feel so good. This blue thing just balled out. All right, so surgeon gave too skinny of a screw, surgeon put too few screws, surgeon put too short of a screw. So if you don't put a long enough screw, then all the weight is on kind of the hilt of that neck of the screw, right where it comes out of the pedicle. So it's more likely to fracture. So the surgeon put too few screws, too short of screws, or too skinny of screws. Those are 3 variables, okay? The next is the surgeon did not put a big enough cage in your inner body space. So they didn't put a cage at all, or they didn't put in anything. So why do you need something in the inner body space? Well, the inner body space carries 85% of the weight of your body, goes through the disc. And if your disc is incompetent, which yours would be if you're having a fusion, I assume, then the surgeon needs to clean the disc out and put a big, tall cage in there. That's what we do. We just did one of these this week, 2 days ago. You see the herniation right there?
Yes, we do.
Oh yeah, here it comes. So anyway, if the surgeon puts too short of a cage, not tall enough, then guys, why is the suction not on this bag? It's starting to pool, okay? So if the surgeon puts not tall enough cage in your inner body space where your disc was, then that means you have too much weight on your screws, on your posterior construct, and they will fracture. In other words, the surgeon needs to put a good size cage in your disc space. Very hard to do. Most spine surgeons are chicken. They're afraid to put a big cage because they don't want to damage the nerve as they're putting the cage in. You starting to see the problem here? Most of the reason screws fail is because of the surgeon, not the patient. But they'll blame you. They'll find a way to blame you. Trust me. They will find a way to blame you. Now, the other reason is pseudoarthrosis. In other words, your fusion never took. More herniation right there coming out. Each one of those blue things is a herniation. And our new animation we're going to have on our new website shows how herniations happen as a bunch of like episodes of little pieces going out through the tear, okay? It's not just one event, it's multiple events. Anyway, getting back to the surgeon not doing a good job. So if they didn't fuse you properly, you didn't fuse, then over time the screws will fail and break. Okay, so failed fusion. And now let's talk about the patient reasons. Number one, the patient did something they weren't supposed to do. All right, that's very common. Lifting too heavy, bending, twisting, going back to work too early, doing things you're not supposed to do biomechanically, stressing the construct too soon. Okay? That's one thing patients can do. Get into an accident, fall off your bike, I don't know, slip and fall, drink some Budweiser beer, too many Budweiser beers, and then you get drunk and you fall off some stairs. Okay? Or trying to skateboard off the roof of your house into your pool. I mean, just watch Fail Army. You can see all the patient reasons why screws would break. So, as long as the patient didn't do anything they weren't supposed to do, another reason that the patient could have failed screws and it's their fault is they have bad bone. They're not fusing because they have bad bone. All right, it's not something that the patient does intentionally, but you may have a low testosterone or you just don't make bone quickly enough, and too much stress on those screws causes them to fail. So there's a lot of reasons for failed hardware. Many of them are surgeon related, and some of them are patient related. Another one is not wearing your back brace after spine surgery, after fusion. You know, your surgeon gives you a back brace to wear, you got to wear it. It gives you support.
Thank you.
Maybe not doing the right therapy, doing too much. So anyway, be mindful that it could be the patient. I have had patients break their screws. I had one guy, I did his surgery, fusion, and he was riding his bicycle 2 weeks after surgery, and he hit something at night, like a rock, flew over his handlebars, and hit his head on the asphalt, and literally fractured the screws in his neck. But it's not common to have broken screws, but it does happen, and it can either be because of the patient or the surgeon. And honestly, it just depends on the individual circumstances of the patient and what's going on. There's one more. That is, I don't know where your screws were put in, but let's just pretend for a moment you're out of the country. They're not in the United States. They're somewhere else. Maybe I'll just pick a country, say India, and you had your screws put in India. Well, there's no, look at the red stuff. There's no FDA regulation of screws in India, okay? So the Federal Drug Administration of the United States only make sure that in the United States the things that doctors do are done, properly with proper testing first. But less than 5 minutes, 2 minutes. But in other countries, there is no FDA, and you may be getting a screw that's poorly designed or poorly built. Poor qualities of metal. So I guess that's some pretty common answers to the problem, but I'm not sure what your situation is, obviously.
We have another question.
Uh-huh.
This comes from JMC once more on YouTube.
Yeah, 2 minutes left, maybe 3. Go ahead, JNC.
They asked, is Medtronic Voyager pedicle screws good screws for lumbar fusion?
Great question. I don't use the Medtronic Voyager pedicle screw system. I don't use Medtronic. I don't care for Medtronic personally. Not because their screws are bad, but I don't like their, what are called the instruments. So when you're looking at instrumented spine fusions and stuff, there's 2 things you have to take into consideration. Number one, the quality of the implants, which is your cages, your screws that we're talking about, right? Properties of those implants. And the second issue is the instruments you use to put them in, okay? So think about it this way. If you're going to go to the kitchen and you're going to make dinner, you got two things you got to worry about. The ingredients, like the quality of your ingredients, are they good? And that would be the quality of the implants, which I don't think there's anything wrong with Medtronic's quality of their implants. And then you got your your kitchen utensils, your frying pan, your oven, those things where you're actually using to make the dinner, right? To make the meal. So you got the ingredients and you got the instruments, the kitchen utensils. If one of your ingredients are bad, you're going to have a bad meal. And then on the other hand, if your equipment in your kitchen is bad, you're going to have a bad meal. So what I don't like about Medtronic's stuff is the tools used to put the screws in. I don't think they're designed well. I think they're dangerous. I stopped using them years ago. I used them about 21, 22, 23, 24. There's calcium right there. There's bone spur. I just zapped it away 25 years ago. And sure, they've probably changed a few things, but I don't think changed that much. Anyway, back then I wouldn't use it because I found that other companies made better equipment. And I switched to those other companies and I use them currently. That's just kind of surgeon preference, but I think it makes a difference. Otherwise, I don't think a screw is a screw. You'll hear people say that in the industry. Oh, a screw is a screw, but it's not. I think every one of those systems is designed differently, and some of them are just better than others. I try not to use any of it because I'm a big believer in endoscopic surgery now. I don't use metal anymore. I rarely do. Try to avoid it. So, anyway, that's my answer. I hope it helps.
We have a comment or seeking for advice coming from Daniel on YouTube.
All right, sure. 1 minute. Hi, Daniel, sure.
They said, I was just wondering if you could talk about how important it is for a doctor to reassure patients that they are fine and doing well. Just a little bit from a psychological standpoint.
Sure, Daniel. So Daniel's asking me how important is it for doctors to, be able to tell their patients, hey, everything's okay. I think as long as everything is okay, that it's important. But I think it's also important you're honest with your patient. And if everything's not okay, you tell them it's not okay. But I do agree with you. I think doctors should talk to their patients, should have a relationship with their patients. I give all of my patients my cell phone number, 100%. All of my patients, I do surgery, they get my cell. And they can call me. I'm not afraid to take calls from my patients. I'm happy to hear from them when they call. The good news is they never call me. I mean, it's very rare I ever get calls from my patients. Because 9 out of 10 times they don't need me after surgery. And they just go on and live their lives. But about 1 out of 10 may need some help, and I want to be available for them. Well, it's interesting here, Berndes, because I thought I would be done quicker, but just about. Literally 30 seconds, I think we'll be done. This has got to be it right here. I mean, I must have been in the disc deeper than I thought just because he must have been twisted a little bit. There's a little bit of calcium here. That's what we're seeing. And I'm just trying to clean it all up for him. Just about out. Really right on the cusp of being outside the disc right here. Yep, we're outside now. Here we go. Done. Let me just get this. What do we got there? That should be it. I'm surprised how much herniation there was. That's a piece of herniation right there. It's calcified, but it is. Nonetheless, done. This should heal nicely. I think he's going to do great. Huh. Wow. Fascinating to me. You guys see a little fat there in the foramen? We're done.
Lights on, please. Thank you.
Scope off. What other questions do you have there for me, Han?
No current questions.
Great, thank you. Well, we are done, folks. And if there's not going to be any questions, we'll just wrap up this broadcast because patient did very well. Ventilating good?
Did great.
Yep. My anesthesiologist says he did great. So, and we used no painkillers, by the way, no painkillers. Not a single painkiller used. Just propofol sedation, which is a sleepy medicine. All done. Let's show you the incision. I'm sorry?
It's a more balanced technique to be used.
Is that better or worse?
Way better for
If there is narcotic. Yeah, but he didn't want any.
No, I
Yeah.
whatever.
So look at that. That's 5 mm incision. We just repaired a thoracic disc herniation right where his pain was. I had him mark it out before surgery. We'll put a Band-Aid on there and he'll go home today with his daughter. They're visiting from Brazil to have his surgery at Duke Spine Institute. Thanks for joining us today, and I hope you enjoyed watching our surgeries. Great job, team. You all did wonderful, and we'll see you all next week. Thanks for joining us, and happy to join us next week for some more spine surgery.